Chamanti, go to your first slide.
And I think Chamanti should stop sharing the screen now.
It's all right. Let it be. It's okay. Yes.
Yes, ma'am.
Good morning, everyone. On behalf of the Indian Academy of Neurology Young Neurology Forum, so myself, Dr. Saraswati Nashi, and Dr. Jyotsna AS, privileged to have you all today in this interesting series of case discussions we are having. So we have esteemed senior moderators today. We have Dr. Shruti Nair, who is a professor of neurology from Sri Chitra Trunal Institute, and we all have seen Madam in many conferences, have benefited from her immense knowledge, and I'm really happy that Madam agreed to be a part of this session. And we also have Dr. Sharat Kumar sir. Sir is extremely approachable, very helping neuroradiologist for us. I think almost all of us in Bangalore have gone to him for any tough cases we have ever faced. So thank you, sir, also for joining this. I would like to now call Dr. Shruti Madam to please take over this session.
Thank you very much, Saraswati, for your kind introduction, and both Saraswati, Jyotsna, and all the organizers for giving me an opportunity to be in this forum today. It is a great privilege. I think we have three very exciting cases to look forward to today. And so without wasting any further time, I would like to invite the first moderator, Dr. Reshma Sultana Sheikh. She's Assistant Professor of Neurology in Nizam's Institute of Medical Sciences. And she is one of the most energetic and, very curious persons I have, and academically oriented people I've met. So welcome, Reshma, and take over the stage, please.
Thank you so much, ma'am. It's a pleasure to be sharing this platform with Shruti ma'am. I look up to her, and I would like to thank Saraswati ma'am and Jyotsna ma'am for this wonderful opportunity. Now I invite the first presenter, Dr. Ripal Neema from SIMS Indore, to present her case. She's a final year resident from Indore SIMS Hospital. Over to you, Ripal. Please present your case.
Shall we start with Dr. Chamanti otherwise?
Sure, ma'am.
Reshma will start Dr. Chamanti, I think.
Okay.
She's already shared her screens.
Dr. Chamanti is my final year resident, so she's worked very hard on this case. And I request Dr. T. Chamanti to present the first case. Chamanti, please, over to you.
Yeah.
Start presenting.
Good morning, ma'am. Thank you, ma'am, for this opportunity. Myself, Chamanti, neurology resident from the Nizam's Institute of Medical Sciences. Here I am presenting a case which is initially easily diagnosed, but eventually there is a diagnostic challenge. So I am presenting it as enigma of a spastic ataxic syndrome. So here is a 36-year-old government employee. He had an history of swaying while walking to the left side in May 2022 for a period of 10 to 12 days. And he improved spontaneously. He did not seek any medical attention for the same. So he was completely asymptomatic for a period of 2 years. After 2 years, he started noticing that there is a stiffness in the left lower limb, which is associated with the dragging while walking, and also noticing difficulty inserting the left foot into the chappal. However, there is no history of difficulty in gripping the chappal or any other sensory disturbances. In addition to the above complaints, he also had swaying to the left. He sought medical help after a month. He was treated at local hospital and improved completely. And however, there is no history of slippage of chappal or difficulty in gripping them. There is no history of difficulty in getting up from squatting position or any other limb involvement. No history of sensory disturbances. No history of bladder and bowel disturbances. No history suggests of any other cranial nerve involvement or the extrapyramidal involvement or any other cognitive domain involvement. There is no history of increase in symptoms on exposure to the heat or prodrome of fever. No history of swellings over the face or neck. No history of rash or CTD features like arthritis, early morning stiffness, or orogenital ulcerations. And there is no history of weight loss or loss of appetite. Here is a summary. 36-year-old male government employee with no prior comorbidities now presented with an history of relapsing and remitting neurological illness with lower limb spastic monoparesis with left-sided ataxia with no sensory, no bladder, no cranial, no extrapyramidal or cognitive involvement or any other systemic involvement. Neurological deficit considered here is a left crural spastic monoparesis and the left cerebellar ataxia. Anatomical site considered here is a asymmetric lesion above L1 affecting the corticospinal tract and the spinocerebellar tract, or any asymmetric left cerebellum and its connections anatomical site was considered. And the pathology considered here is an acquired in view of asymmetric and relapsing and remitting nature of the illness with a possibly immune mediated mechanism because as it was steroid responsive at the second attack. And the etiologies considered here are primary demyelinating illness, that is multiple sclerosis, and the inflammatory, that is neurosarcoidosis, and the vasculitis Behçet's disease was considered. And the less likely possibilities like adult onset leukodystrophy, that is adenomyeloneuropathy, metachromatic leukodystrophy, and adult onset Alexander's disease was considered. And CSF1R mutation was also considered. And here is a diagrammatic representation of a clinical course of his illness. In 2022, he had cerebellar ataxia. It was improved completely over a period of 10 to 12 days, and he was completely asymptomatic for a period of 2 years. After 2 years, he had an history of cerebellar ataxia with spasticity, with ataxia improved after IVMP with residual spasticity. And in 2024, he had again one more attack in form of cerebellar ataxia and the spasticity. With these complaints, he came to NIMS. With the persistence of these complaints, he came to NIMS. And we went ahead with the neurological examination, that is HMF is normal, cranial loss, visual acuity 6/6, visual fields were normal, there is no RAPD, fundus was normal, and extraocular movements were full, there is no nystagmus, saccades and pursuits were normal, and there is no other cranial deficit. Motor examination, tone, grade 1 spasticity in both the lower limbs, and the power is around 5/5, plantar reflexes is bilaterally extensor, and the deep tendon reflexes, knee and ankle were brisk on the left side. And sensory examination is normal. Cerebellum, bilaterally impaired finger nose test and heel knee shunt test, more on the left side is noted, and the tandem gait is impaired. So after the examination, here is a summary with a relapsing and remitting neurological illness with left more than right hemiataxia, with left more than right spastic crural paraparesis, with initially responsive to steroids, now in a progressive course of illness in a 36-year-old gentleman with nil comorbidities, without any other neuroaxial involvement. So etiologist was
Chamanti?
considered.
Chamanti,
Yes, ma'am.
Yes, ma'am. Shruti, ma'am, please go ahead.
Yeah, thank you. There are a few, excellent presentation. So there are a few clarifications I would like to ask in terms of localization.
Yes.
One thing is that suppose a patient has, historically we thought that it was unilateral. There was both cerebellar and pyramidal on the same side.
Yes, ma'am.
So one of your localizations was spinal cord, right?
Yes, ma'am.
So simultaneous involvement of pyramidal tract and the spinocerebellar tract. Are there any other localizations where this is possible?
According to history, there is a ataxic spastic hemiparesis was there, ma'am. So for an ataxic hemiparesis, we can consider 5 localizations in the supratentorium, in the coronary aorta, in the internal capsule, and also in thalamus. We can consider these 3 sites. And in the brainstem, involvement of the corticospinal and the cerebellar connections, that is either in the midbrain, that is superior cerebellar peduncle along with the crus cerebri involvement, or in the pons in form of pontocerebellar nuclei and the cerebellar peduncles, ma'am.
It's excellent. So this is because the dentatorubro-thalamic fibers cross. That is the reason for the midbrain and above abnormalities, and as we were mentioning, the pontine nuclei and the corticospinal tract. That is for the pontine. Excellent. So now on examination, you find that rather than unilateral, it is asymmetric. Now, based on the story that you have mentioned and the differential diagnosis that you have put, which one would you prefer?
As it is relapsing and remitting nature, and also there is a immunological response with the steroids in the second attack completely, and so possibilities, initial possibility considered are acquired only, ma'am. Like primary demyelinating disease like multiple sclerosis and the NMO and other demyelinating conditions were also considered, ma'am. And secondary inflammatory conditions like neurosarcoidosis and vasculitis were considered, ma'am.
So in general, when you think of demyelinating illness, the pathognomonic way it would present would be dissemination space. So if it is occurring in the same site, if you are able to localize to the same site over and over again, we are slightly worried whether it is a demyelinating or not. That being said, I would always say that there are any number of demyelinating that I've seen which have localized to a single site. But the classical feature would be they would present at a different site at different times. So if that is there, then demyelination is unequivocally the strongest possibility. Now, the situation with neurosarcoidosis patients, in addition to the systemic problems that they also have the tendency to occur in the same place again and again, and they recur usually at the same site, and they then spread to other sites. So that kind of involvement should make us think of a possibility of a focal inflammation. Either this, even IgG4 disease can be like that. And I think that just because of that, there is a slight thought whether it is not just a demyelinating illness or not.
Yes,
So how much do you think about leukodystrophies as a possibility? How
it
likely?
is very less likely possibility, ma'am.
Yeah.
But spastic ataxic syndrome was considered and keep that as a differential diagnosis, but very less likely possibilities.
Agreed, because this is a complete remission in between.
Yes.
And that asymmetry, generally it is a point against it, and CSF1 tendency it generally presents with dementia kind of presentation. Good.
Yes, ma'am.
All right. Anything else, Reshma, to add?
No, ma'am. I mean, these are the points which we wanted to discuss as well. And I just wanted to ask Chamanti one question. When we keep cerebellum and its connections as localization and without any involvement of speech or eye abnormalities after your examination, how can you explain this kind of cerebellar localization? When there
Either
is
the cerebellar peduncle is one possible localization, ma'am, and also either spinocerebellar, but spinocerebellar is more of a unconscious proprioception rather than a. He had also difficulty in reaching the chapel also, ma'am. It's a conscious decision to reach to the chapel. He had a dysmetria as well, so cerebellar peduncle is more likely possible. But however, patchy lesions in the cerebellum can also cause without any speech involvement.
Right. Okay. Ma'am, if it is fine, can we go ahead, ma'am?
There's just one more question. Would you consider mitochondrial here? That is one question that is from the.
Because of the relaxing and remitting nature, but there is no prodrome of illness prior to this, ma'am, and there is no drug intake prior to this. But the relaxing and remitting nature need to keep the possibility, but it is less likely.
Yeah, and
it
also
is
the predominant white matter.
Yes, ma'am. And it is immune mediated, immune responsive also.
That is very difficult to say because we do not know what they responded to. It could be spontaneous recovery also.
Spontaneous, yes. Okay.
Thank you. I think we should go on.
Okay. He came with this images from the outside. This is a T2 flare axial image, which is showing hyperintensity lesions across the corpus callosum and also in a deep white matter, and also in bilaterally parieto-occipital region. Subcortically, there is a bilaterally symmetrical hyperintensity lesions were noted in the flare image. On a T2 axial image, similar lesions in form of hyperintensity lesions in across the corpus callosum and also in deep white matter and also bilaterally parieto-occipital region, there is a subcortical involvement is there. In a T1 axial, usually white matter should be white. And in here, we can see hypointense lesions across the corpus callosum and also in deep white matter and also bilaterally parieto-occipital region. There in the subcortical region, we can see hypointense lesions. Along with that, we can see there is a bilaterally parietal atrophy and also temporoparietal parieto-occipital atrophy can also be seen in a T1 axial image. And here is a sagittal T2 sagittal section, which is showing finger-like projections, which are perpendicular to the corpus callosum, and as if they are looking like a Dawson's fingers. And in a T2 coronal image, here is hyperintensity lesions across the corpus callosum and also in parieto-occipital, suboccipital region, there is an hyperintensities were noted. And here is a diffusion weighted image. In the diffusion weighted image, there is no diffusion restriction. However, we can see there is a T2 shine through, which is noted across hyperintensity lesions, which are across the corpus callosum and also in the deep white matter, and also mainly on the parieto-occipital periventricular region. We can see there are hyperintensities. And also on a contrast imaging, here we can see there is a nodular enhancing lesions mainly in the anterior part of the corpus callosum, that is rostrum of the corpus callosum, and also on the periventricular region there is a nodular hyperintensity we can see. And on a sagittal image, we can see there is a nodular hyperintensity which is on the rostrum of the corpus callosum, which is anterior to the rostrum of corpus callosum. Here, T2 sagittal section spine imaging showing hyperintensity, but that hyperintensity is just behind the spinal cord. This is more of a flow artifact rather than a true lesion. And handles considered after the imaging or after the history examination and the imaging were initially relapsing and remitting course, progressive after the third clinical attack, and partial response to the immunotherapy, with imaging being symmetrically white matter hyperintensities across the corpus callosum, periventricular region, subcortical parieto-occipital region, and also tracking along the corticospinal tract with a nodular contrast enhancement is noted. And with these handles, we consider the differential diagnosis were multiple sclerosis because of its relapsing and remitting nature of the illness and the partial response to immunotherapy. And in our imaging, we can see there is a dissemination in space and also dissemination in time. We can note it in form of periventricular lesion across the corpus callosum lesion, and also there is a T1 contrast black holes were noted, and also contrast enhancement is noted. But the contrast enhancement is very nodular, which is odd for the multiple sclerosis. Because of this reason, we can consider the neurosarcoidosis and the vasculitis. But however, because of the bilaterally symmetrical involvement is a points against for the multiple sclerosis as well as the neurosarcoidosis. And the points against for the vasculitis were we did not see any cortical involvement, and there is no deep gray matter involvement, and there is no blooming in SWA imaging. SWA imaging was done after the second time, and there is no blooming in a SWA imaging on the second. And because of its presence of bilaterally symmetrical parieto-occipital hyperintensities, we considered the metabolic and the genetic conditions as well. But the relapsing and remitting nature, partial responsive to immunotherapy, and the enhancement pattern are all the against features for X-linked adrenoleukodystrophy and also hyperhomocysteinemia. In a CSF1R mutation, we can see there is a bilateral white matter hyperintensities in the T2 and flare, hypointensities in T1, but there is no diffusion restriction, and the clinical syndrome usually subcortical pyramidal involvement. So the less likely possibility, but the imaging features are suggestive, so we kept as a differential diagnosis. And with this, considering these differential diagnoses, we went ahead with the investigations to rule out, to consider by considering the demyelination, CSF OCBs were done, which are negative, and CSF NMO and MOG were done, which are negative. And considering the vasculitis, we have done ANA, ANCA, RA factor, ESR, CRP, all were negative. And ANA blood is also negative. So considering the possibility of neurosarcoidosis, we have done serum and CSF ACE levels, which were also normal. And the routine investigations and vitamin B12 and folate were also normal. So we went ahead with the baseline imaging in NIMS. So in this baseline image, we can see T1 hypointense lesions, T2 and flare hyperintense lesions across the corpus callosum and deep white matter, and in the bilaterally parieto-occipital subcortical region. And also we can here in spinal imaging at December 2025, we can see there is a hyperintense lesions which is across the C1 and C2 region. So here we can see spinal cord lesion as well. In a sagittal section, there are finger-like projections which are perpendicular to the corpus callosum, which are perpendicular to the ventricle. So they are appearing as a Dawson's fingers. And on contrast imaging, we can see there is a nodular enhancement in the left temporo-occipital region, and also on a subpile contrast enhancement with a nodular enhancement. So with these features, we can say there is a dissemination in space and dissemination in time. In a 3 months prior scan, we were noted that there is a nodular enhancement in the anterior part of the corpus callosum. Here, the lesion is on the left temporo-occipital. And also T1 black holes were noted with the periventricular lesion, subcortical lesion, and spinal cord lesion. So it is fitting into the criteria of McDonald's 2024. So dissemination in space is there, dissemination in time is there. So we considered more of multiple sclerosis rather than MS mimickers. We have ruled out the MS mimickers by doing vasculitic profile and the other demyelinating workup and neurosarcoidosis workup. So we went ahead with the highly aggressive therapy because he is a young male with extensive lesions. Highly aggressive DMTs were considered with natalizumab. So after he received 3 doses of natalizumab and he reported there is no improvement or worsening. However, after the 4th dose, he had worsening in gait and also involvement of the left upper limb and inability to perform all the activities of daily living independently. So, because of this worsening after the natalizumab therapy, which made us to revisit the diagnosis before telling it as a progressive MS or a complication of natalizumab. So, he was readmitted again and repeat imaging and repeat investigations were done in August 2025. So here we can see same lesions, but there is an increase in number of lesions and also an increase in number of site we can see. Here in a deep white matter, when compared to prior scan, there is a increase in T1 hypo and T2 flare hyperintense lesions in the deep white matter and also in bilaterally parieto-occipital region. And in spinal cord also, we can see there is an extensive involvement involving the medulla and also C3 part of the spinal cord. Priorly, it was only C1 and C2. Now it has extended the lesion into the medulla as well as into the C3 region. So after natalizumab, there is a worsening of the lesions we have noted. Even on contrast imaging, we can see there is a nodular enhancing lesions which are present in the deep white matter, which are the number has been increased and size has been increased. Now we can see on the right temporo-occipital region, there is a nodular enhancement. And also in a spine imaging, there is a subpile enhancement. Along with that, there is a nodular enhancement in the medulla as well as in C1 region. And here is a SWA imaging which is showing perivascular nodules along the small vessels. And also we can see there is a sparing of the subcortical U fibers here. So there is no juxtacortical involvement in this case. And there is a perivascular nodules were also noted. So imaging findings in third scan, almost all the lesions have flared up and edema and number of enhancing lesions have shown significant interval increase. So
I
further
think, Samantha, at this course, we should discuss
Yes.
the imaging.
Yeah. Yeah, I think I can take over because most of the slides we have prepared and it is discussed nicely. So if you see the first images which was done outside, we had no original images, but the images were taken from the films, so they are a little bit blurry. And if you see, they are not exactly symmetrical, but they are somewhat close to symmetrical lesions because they have all the lesions have confluenced in the first imaging itself, and they appear like they are like a leukodystrophy or a predominantly white matter lesion, which is centered around the periventricular white matter as well as the corpus callosum. You can see that in the axial sections, these flare axial images, you can see that horizontal bands, the linear bands which are running parallel to each other, which says basically the corpus callosal involvement. And also we could see that how the corpus callosum is already showing multiple punched out type of lesions involving the callososeptal area. And almost in the T1 weighted images, you can just show the other images. It will be useful. Yeah. You can see this. These are the plane scans actually. You can already see that the black holes like picture are already appearing, and these are pre-contrast. Already a lot of neuronal loss, the volume loss has started setting in. And if you go to the next slide where the corpus callosum is shown, yeah, you can see the significant part of the corpus callosum is involved, starting from the anterior genu, entire throughout the body, going up to the splenium, and in these parasagittal areas, you can see that linear lesions. All the lesions are linear, running away from the corpus callosum and periventricular area as if it is mimicking a dozen fingers. It's very easy to get confused when you see these callosal involvements, callososeptal involvement, and periventricular lesions running parallel and perpendicular to the callosum. We think of more of a multiple sclerosis in the initial, but there were some odd points which were not fitting into these classical multiple sclerosis like picture one. If you see generally the periventricular white matter, the peritemporal horn around the temporal white matter, usually that is one of the favorite site for the multiple sclerosis. When we see such a huge burden of lesions in the body of the lateral ventricle, we do see some lesions in the peritemporal horn. Probably that is one of the key imaging finding how we differentiate MS from MS mimickers in general. That is one point. And also the involvement of the white matter, which is close to the cortex, as in the last slide she showed, there was a sparing of subcortical U fibers. The subcortical U fibers says that they are not classical cortical or juxtacortical lesions because it should get involved. We should not be getting that sparing of that. So we cannot label it as a cortical juxtacortical lesion. Predominantly lesions are labeled as periventricular white matter or the deep white matter. Even in this slide, for where the SWI, we generally see either paramagnetic rim lesions or the central vein sign. Here it's all more of nodular, which is running all along the vessels. If you see in this SWI on the right side where the red circle is marked, you see the dots, not the lesion with the linear running vessels. It's not the classical central vein sign. It says that the lesions are centered around the perivenular or vascular pathology, perivascular nodular type of appearance, not that classical central vein sign, which should be ideally demonstrated in two different planes in the center of the lesion. But all these lesions are confluent, which another point which is difficult to make out whether it is true central vein or more like a nodular SWA lesions. And coming to the other thing, the other lesions, the other locations, classical locations like infratentorium. In the initial scan, we could not see any spinal cord involvement. The peduncles, all those other typical sites were spared. And the most important clue was the enhancement pattern. I agree, multiple sclerosis can show, or any demyelination can show any type of enhancement, particularly open ring, close ring. But every time consistently this type of enhancement is very solid and nodular rather than that incomplete rim or a complete rim. This was also a very odd point. And more of the lesions, even in the card, if you see, there are subpial nodules. And these nodules are all situated all along the perivascular areas. So there are some points which are very, very odd for classical demyelinating disease like multiple sclerosis. And that's why we were, and also if you see the clinical course and how the patient worsened after that, are all not in favor of. If you go to that slide where there was a differential diagnosis you had put so that we can easily rule out. Yeah, initially. This table, yeah, that table is gone. Yeah. So these were the points which were against multiple sclerosis. And neurosarcoid, yes, agree. In neurosarcoid, we can get these typical nodules, subpial nodules, linear nodules, or linear vascular enhancement that can bloom. The brush sign, which we describe on SWA, can also be seen in neurosarcoid. And the odd point was a little bit the more confluent white matter changes, the typical callosal involvement, which are not classical. Neurosarcoid is more of leptomeningeal nodules and pachymeningeal cranial nerves. All those were not there. And the primary vasculitis, usually the primary vasculitis also affects multiple infarcts of variable ages with or without microbleeds. All these are also were missing. The cortical lesions were completely missing. Then X-linked ALD is very easy, classical. Usually the splenium part of the corpus callosum is exclusively involved. The characteristic enhancement pattern, all those were not there. CSF1R mutation is also not a classical imaging picture. We get that stepping stone type of calcification, nodular dots of restricted diffusion. This type of corpus callosal involvement and striations, nodular enhancement are not described in CSF1R mutation. When hyperhomocystinemia, the enhancement distribution, especially exclusive callosum, they were also not fitting into the imaging. So we were somewhere dealing with a pathology which is centered around the vessels, and they're all like a non-caseating granuloma, somewhat like a granulomatous angiitis like of picture, more than the multiple sclerosis like picture. Still there are no classical imaging feature to pinpoint one disease, but more towards the till now the imaging pattern fits more towards perivascular granulomatous angiitis like of picture, and still we have to see how the patient evolve. And somebody was asking whether it is GFAP or lymphoma. Lymphoma, usually the intravascular lymphomas can mimic this type of picture. The angiocentric lymphomas or intravascular lymphomas, they're seen in elderly. Typically, they mimic like infarcts or the leukodystrophy-like pattern. But this type of, there was absolutely no restricted diffusion in any of these pictures. And you may get blooming as well. In this case, there was no blooming. And that type of pattern was not fitting in this, that typical callosal involvement punched out of lesions, linear perivascular, and enhancement also was hard for lymphoma. Either the mass-forming lymphoma or the intravascular or angiocentric lymphoma or lymphomatosis cerebri, they were not fitting here to that picture. And the patient had a lot of long history, relapsing and remitting type of quite long duration of 1 or 2 years. That also was hard. And GFAP, very easy to make out. We get a spoke wheel type of linear enhancement in the periventricular white matter, and other findings, subpile enhancement or nodules can be seen in GFAP. And this type of leaving the scars behind, like thinning of the corpus callosum, black holes, are not very classical of GFAP. So I think we should continue with this imaging findings in background so that we can build up in coming slides.
Thank you, sir. I'll just also add, excellent points by Dr. Sharath there. I would also add 1 or 2 more points. One is that the corpus callosum involvement, you can see that the body of corpus callosum seems to be very markedly affected compared to the anterior aspect.
Yeah, yes.
So that also is not very classical of MS. And in general, I like to see if what the majority of lesions look like. Are they most of them MS typical, or are they most of them non-MS typical? So although we do find all the, if you apply the criteria, you might find lesions in the correct locations. But the majority of them are subcortical or diffuse confluent lesions. I think we should, keep other possibilities wide open before we conclude the diagnosis.
Yeah, the one more point, ma'am, before we continue, even the spinal cord involvement.
Yeah.
More like a 2-3 segments are involved, at least 2 at least here is involved, though it still fits into the short myelitis. But the axial sections which was shown was mainly the central cord is involved rather than the quadrant of a cord or a transversely. It was more extensive in nature in that. Whether it is, if you see the last, before that, this one. If you see the axial sections of the spinal cord, it's not like one quadrant or a part of the spinal cord. It's more centrally placed rather than, which is not typical for multiple sclerosis also. So this was also point against classical picture.
And there is some evidence of meningeal involvement, no? And that.
Yeah, meningeal involvement and nodules, meningeal based nodules are also hard. This enhancement pattern itself is hard.
So thank you so much. I think hindsight, we can find many things. And but I think I do agree that initially there was a good amount of confusion whether this was a progressive MS coming up or not, even historically, with a very nice response to steroid. Shall we continue?
Yes.
Sharath sir, I just have one question for you, sir. If we look at the spinal cord, does it look like some kind of a trident or an inverted trident on the axial section, or it doesn't look like any of that in this?
No. Yeah, it doesn't look like that. Usually the trident is classically described in post-contrast axial sections, where subpile rind of enhancement, central canal becoming prominent and showing enhancement, the dorsal subpile enhancement.
Yeah.
Here, if you see, even in the axial section or in the post-contrast, you don't get that classical trident type of appearance.
Okay, sir. Thank you.
It starts posteriorly rather than this is more central.
Dorsal surface, yeah.
Yes, thank you, sir. Ma'am, shall we go ahead with Chamanti's presentation?
Yes. I think we'll discuss everything at the end of it, the questions.
Thank you, sir. Thank you for your input, sir. And further course, after this third image, after the natalizumab, we had a worsening of these lesions and persistence of these perivascular nodules and sparing of the subcortical U fibers. Almost all the lesions increased after the natalizumab. And so patient had both clinical and the radiological worsening. So hence the diagnosis of MS was revisited and the possibility of neurosarcoidosis and the vasculitis were considered. So he was investigated on these lines. So we repeated all the investigations with the CSF analysis. Cells were normal. There is a mild protein elevation, suggestive as an inflammatory condition, with the sugars being normal and cells being normal. CSF OCBs were sent, which are negative, and repeat demyelination workup NMO, MOX sent negative, and serum and CSF ACE levels were sent negative. Here we have done extensive vasculitic workup in form of HLA-B51, which is negative, and the pathogy is also negative. Visual evoked potential is suggestive of bilateral anterior visual pathway involvement in form of P100 latency has been increased with a left side being 126 milliseconds and right side is 130 milliseconds. So we went ahead with the PET imaging, and the PET imaging suggestive of hypometabolism in a bilaterally sensory motor parietal area and the posterior putamen and the posterior thalamus with a bilaterally lateral temporal cortex and bilaterally cerebellar hemisphere also there is a hypometabolism, which is indicative for the cell injury. And when the whole body imaging suggestive of there is an hypermetabolism, which is circumferentially hypermetabolism along the walls of the right common carotid artery, and also there is a circumferential hypermetabolism along the walls of ascending aorta and the descending thoracic aorta. So FDG avid uptake is seen in the vessels, suggestive of vasculitis. So here is a linear diffuse uptake in the vessel wall is highly indicative of large vessel vasculitis. In case of atherosclerosis, usually there is a focal, patchy, low-grade uptake is common observation. However, FABI-PET is the best modality for active vasculitis. FDG avid uptake usually is seen in active lesions and also as well as in regenerative lesions. And further course, with the PET suggestive of vasculitis, the patient was treated with the pulse steroids followed by anti-CD20 therapy with the rituximab. That is 1 gram on day 1 and the day 15. He was advised about the adult vaccination schedule before this anti-CD20 therapy, and he showed clinical and the radiological response in follow-up. So here we can see all the images with the first and second are prior to therapy. Third is after natalizumab. Fourth one is after rituximab therapy. When compared to second and third image, we can see there is an hyperintense lesions in the deep white matter and also bilaterally parieto-occipital. Their lesions has been increased. When compared to third and fourth scan, we can see there is a reduction in size of the lesions in the deep white matter. And this axial T2 axial image, which is also suggestive of increase in hyperintense lesions on the third scan. When compared to third scan, there is a fourth scan, there is a reduction in the lesion size. And even on the coronal and sagittal image, same is suggestive. In FLAIR image, we can see clearly there is a hyperintense lesion increasing in third image, whereas in fourth scan, there is a mild reduction in lesion size. Even the contrast enhancing lesions were more in the third scan, and they were disappeared on the fourth scan. Lesions were reduced and the lesions were not appearing on the imaging. And on sagittal image also, we can see more lesions in a third scan when compared to fourth. So after rituximab, patient had radiological improvement as well. Even in the sagittal spine image, we can see when compared to third and fourth scan, there is an increase in lesion size extending into medulla and C3 region. So it is involving more than three vertebral segments. And also when after rituximab therapy, we can see reduction in lesion size. And also we are not able to see the hyperintensity lesion on a spine. And persistence of this subpile enhancement with a nodular enhancement is noted in all these scans. So after all the scans, we even though there is a dissemination in space and time, the nodular contrast enhancement and the no lesions in peritemporal horns of the lateral ventricle, and there is no juxtacortical, typically sparing of these sites with extensive lesions is odd point for the MS. And also even after natalizumab, the increase in lesions is also odd point for the multiple sclerosis. And the presence of nodular perivascular lesions and also subpile contrast enhancement is around the small vasculature is clinching, and it is a suggestive for more of non-caseating granulomatous lesions, possibly neurosarcoidosis, possibly vasculitis. And here after rituximab therapy, he was able to do the tandem. There is a mild ataxia, but he was able to do after rituximab. And this is the gait video. We can see there is a spasticity in both the lower limbs when left more than right, and also there is a circumduction of a left lower limb when compared to right. And final diagnosis, conventional imaging is suggestive for multiple sclerosis, but the nodular perivascular involvement and the subpile enhancing lesions following the small vasculature is more suggestive for non-caseating granulomas. And nuclear imaging suggestive of vasculitis. So here large vessel as well as small vessel vasculitis is seen. Large vessel vasculitis in PET we can evidence is there, and small vessel vasculitis in SWA we can noted. So possibility of neurovasits and the possibility of neurosarcoidosis with a secondary demyelination was considered. So here is a article which is published in BMC Neurology.
Before discussion, there are
Yes.
many questions in the forum. We'll discuss that.
Yes.
I also have a few questions. One is that, do you consider Susac syndrome as a possibility?
Vasculopathy, ma'am, but no clinical feature suggestive of ear involvement or the eye involvement or any other involvement, ma'am. And
Yeah,
also confluent lesions.
He never
the
had
present,
it. Yes. Sorry.
presentation itself is out. You were telling, Reshma?
Yes, ma'am. We wanted to just tell that he never had any sort of an encephalopathy-like presentation, like some sort of a confusion or memory loss. That was never his presentation, ma'am. Presentation was predominantly like a crural spastic monoparesis, but on examination, it was more of a bilateral disease. But the clinical features were not looking like encephalopathy kind of a presentation, which is typically described for SUSAC.
Yeah. So I agree that except for the corpus callosal lesions, we do not have much of an evidence to support Susac here.
Yeah, Susac in imaging also, ma'am. If you see the corpus callosal lesion, they spare both the superior and inferior blades of the corpus callosum. They are bang in the center, and most of these are like snowball punched out lesions with the restricted diffusion when they start with generally. Like a snowball. So these lesions, in this case, they were callososeptal interface was involved, no restricted diffusion at any point of time, even in the third scan when the lesion burden increased significantly. And of course, clinically also, it was not matching.
Yeah. Thank you. And there are questions whether one is CNS lymphoma, do we want to consider anymore? Because there is data that there can occur without diffusion restriction. Many times it is after steroid use that you can have lesions without diffusion restriction.
Usually, the lymphomas are greatest mimickers. When we don't get any diagnosis, we should always go towards that side.
Yeah.
Agree? Because we have seen in all CPCs, ultimately, whatever was not diagnosed turned out to be IV lymphomas or all these things. But in this case, if you see those residual lesions, the scarring which was left behind and the patient improving, and consistently no restricted diffusion, though there are exceptions. And these nodular along the granulomatous type of enhancement was very hard for the lymphomas. I've seen so many lymphomas of various type of presentation. These typical nodules which comes and goes, subpile enhancement comes and goes. These are all very hard for lymphoma. And in spite of being such a confluent white matter hyperintensity, not even finding a speck of restricted diffusion anywhere was also a little bit odd, sparing deep gray. So many things were odd, ma'am.
I agree. And also the fact that there was atrophy and gliosis at the end of therapy. Yeah. So the strong.
Because they relentlessly progress. They don't live beyond the scars like this.
Yeah. Thank you. And there are other questions can we consider immunosuppression related CNS infections? So Chamanti, is there anything specific that you would like to consider here? And was
Sorry.
immunosuppression ruled out?
Viral markers were negative, ma'am. Is RVD negative, and there are no immunosuppressive. Even the immunoglobulins were also normal, ma'am. There is no hypogammaglobulinemia or any other immunodeficiency syndrome is not there, ma'am, for him.
Yeah, and for natalizumab, we are only concerned with PML. Yeah.
Yes,
Yeah.
ma'am.
And this is not typical of PML anyway. And
No,
it's the
no,
same lesion that has worsened, not a
And also
new onset
contrast
problem.
enhancement is noted, and there is no confluency of the lesions. And he is not having any clinical picture after natalizumab, like aphasia or any visual deficits or any encephalopathy conditions. The clinical picture is not fitting after this natalizumab worsening.
I agree. So the clinical and radiological is not in favor of a
Not fit.
PML.
Yes,
And
ma'am.
although there are a huge number of infections which can have meningeal and parenchymal involvement, the overall story does not favor that thing. There's a long history with relapsing remitting illness. And there are a few more doubts. Are there any? You have responded to that. Are there any pulmonary aneurysms or ascending aorta aneurysms which should favor Behçet's? And Reshma has responded that it is not there. Okay.
Yes.
Thank you.
There is an input from the head of the department of our nuclear radiology department, ma'am, Dr. Madhur Kumar Srivastava, sir. He's the one who reports most of our PET scans and helps us with most of the diagnosis when we are stuck and when we cannot get an access to the tissue. So, sir usually says this to us that whenever there's a CNS lymphoma on PET, it glares at you. That's what he says all the time. So, the high FDG uptake and all will be there. So, CNS lymphoma PET wise also was not considered. So that we kept, we did not consider CNS lymphoma from the beginning, looking at the imaging pattern like what Sharad sir just described. And after PET also, it was even, we were even more sure that those lesions were more hypometabolic on the brain and they were not glaring at us. So even PET helps us when we are stuck, if it is a CNS lymphoma on conventional imaging, because like sir rightly said, that's always a differential. So in PET, at least we could rule out CNS lymphoma.
Okay, thank you. And for vessel wall imaging, why did you, is there any additional MR vessel wall imaging would have been better rather than FDG PET alone?
That's a limitation in our study, ma'am.
Actually, we could, yes, ma'am. We didn't do that. So we were, that was the major drawback, that we didn't do a vessel wall imaging in this particular patient. We straight away after looking at the PET, we gave him the immunotherapy because we were very convinced that it is a vasculitis related secondary demyelination.
Even for the vessel wall imaging,
Yeah.
the type of lesions and the vasculature which seems to be there, very small vessel vasculitis. If you do a vessel wall imaging, the amount of what we appreciate in the medium vessel, even up to M2, M3 is a good possibility that we get a lot of information from vessel wall imaging, which should be used. But in this case, I don't think it would have added much benefit because the vessel involvement are quite distal and tiny ones, which is beyond the resolution of the conventional MRI, whatever we have, even up to 3 Tesla.
Yeah, thank you. But would there be any benefit? I think angiography was already done, no?
Yeah. I think MRA was
Actually,
not done.
MRI was
Angio was not done, but fine. Anyway, you had this thing. So
Yeah.
I was wondering how specific is the finding of the enhancement of vessels in case diagnosed vasculitis or even the etiology of vasculitis. Personally, I found that the specificity is not so high. If we have a few differential diagnoses in mind, it will definitely help to sort out. And as you have very nicely told how you differentiate atherosclerosis from vasculitis, we have that possibilities. It helps to sort out. But my own experience, the specific diagnosis, of course, is not given by the vessel involvement. You can only think of all the conditions where vessels can be affected.
Yeah, we can differentiate vasculitis from ICADs, all those things more useful. And probably with this type of lesion, the value of vessel wall imaging is quite low, ma'am.
Thank you so much. And Chamanti, why would you consider Behçet's as the first possibility here?
Because of the large vessel as well as small vessel involvement. In large vessel vasculitis is evidenced by PET scan in form of circumferential hypermetabolism along the common carotid ascending and descending aorta, and also small vessel vasculitis in form of perivascular nodules in SWI are the clinching points, small as well as large vessel vasculitis. However, it does not have any other systemic involvement in form of oral lesions or ocular lesion or any genital ulcers. But probable neurobasets can be considered with this thing.
I agree. I personally thought that sarcoid was a better thing, like the parenchymal lesions may be granulomatous rather than vasculitic. And
Subpile nodular enhancement and also nodular enhancement in the brain is more towards the neurosarcoidosis.
But the large vessels are not usually involved, I think. Dr. Sharon?
Yeah, ma'am. Well, because of the large vessel involvement, probably they have brought the neurobasets as the first one because of the PET imaging. Otherwise, if you forget the PET, the neurosarcoid will come before the basets. In the basets, purely vascular, leaving behind the typical diencephalomesencephalic, this waterfall or a cascade sign, that lesion. Those are all not there, which is more classical of neurobaset rather than pure vasculitic or granulomatous form. And that was the one odd point for the neurobasets. Because of large vessel involvement, it has been brought up in front of neurosarcoid. I think even IgG4 or granulomatosis with polyangiitis, all it should be still in the picture, I think, apart from neurosarcoidosis as a differential diagnosis.
Thank you. And I think Dr. Mathur has also added that FTG is better for peripheral vessels, but for CNS MRI may be a better option. All right. Thank you. I think for want of time, we'll now proceed with the discussion.
Amanti, please go ahead, no?
Yes, ma'am. And here is a article which is representing clinical and imaging features of the parenchymal and non-parenchymal neurobasets, which is published in BMC Neurology. Here, the imaging features of a parenchymal is involvement of the brainstem, spinal cord, as well as cerebral hemisphere, with the clinical features being spasticity, bladder involvement, headache, and the ophthalmoplegia are the usual features. Whereas non-parenchymal involvement of CSVT and strokes with thrombosis, dissection are the features of the non-parenchymal neurobasets. And neurobasets criteria, definitive and probable. In a definitive, we criteria should satisfy the ISG criteria, International Study Group criteria for basets, that is oral plus more than 2 genital or ocular involvement with pathogen positivity, and the neurological syndrome recognized to be caused by Behçet's disease with a characteristic imaging and the CSF abnormalities. If either of the one is present, we can consider this as a probable neurobasets. In our case, there are no features suggestive for the ISG criteria, but the neurological syndrome with involvement of the small vessel as well as the large vessel vasculitis, we consider the possibility. And whenever there is a differential diagnosis of multiple sclerosis, we need to consider the neurobasets according to this article recommendation too. And also, whenever there is a stroke affecting the young or intracranial hypertension or meningoencephalitis, we need to consider this as a possibility of differential diagnosis. And how sensitive are the pathogen and HLA-B51? In our case, there is a pathogen positive, pathogen is negative, and HLA-B51 is also negative. So pathogen test has a sensitivity of around 60% in Japanese and Turkish population, whereas it is infrequently positive in European and African population. And HLA-B51 negative genotype is seen only in 40 to 65% of the patients. So testing of this HLA-B51 and 5 does not appear to provide a substantial aid for the diagnosis of neurobasets. And usually the characteristic imaging signs in neurobasets is cascade sign with the involvement of mesodiencephalic junction with the tracking along the corticospinal tract. But however, 30 to 40% of the cases may not have this classical sign, but involving the and tracking along the pyramidal tract can be seen. And characteristic imaging signs in neurobasets is a Beagle sign. And even the neurosarcoidosis with vasculitis, this is a new entity. This is published in Green Journal Neurology. Neurosarcoidosis is a rare manifestation of sarcoidosis. Traditionally, 1 to 2% of the patients with neurosarcoidosis had the vascular involvement. High proportion of the cerebral infarcts, presumably secondary to underlying vasculitis or the vasculopathic process, has been recently described. Involvement of the medullary veins on SWI is a well-known entity in neurosarcoidosis. Criteria for neurosarcoidosis, the clinical presentation along with the diagnostic evaluation suggestive for neurosarcoidosis, along with the definitive histopathological confirmation from the neural tissue, then we can consider it as a definitive. If the histopathological confirmation is from the systemic other than the neural tissue, then we can consider it as a probable neurosarcoidosis. If there is no histological confirmation, we can consider it as a possible neurosarcoidosis. This is a characteristic imaging sign in neurosarcoidosis, that is deep medullary vein sign. Even from our department, we have published the unmasking the great mimicker, that is a neurosarcoidosis in Neurology India. Here we can show that deep medullary venous engagement along the perivascular area. And the isolated neurosarcoidosis mimicking the multiple sclerosis. Here is a 25-year-old male with a transverse myelitis. MRI suggestive of all the lesions of the multiple sclerosis like periventricular, infratentorial, spinal cord lesion. He was diagnosed as MS and he was kept on fingolimod. But after that, there is a clinical worsening, and MRI showed longitudinally extensive involvement, same like our case, with a leptomeningeal enhancement. So they got a biopsies from the cerebellar biopsy, which is suggestive of non-necrotizing granuloma. So neurosarcoidosis can mimic as a multiple sclerosis. So usual the treatment recommendations in neurosarcoidosis is IVMP followed by steroid sparing agent. If the disease is aggressive, we will go with the infliximab. But the case reports can show cyclophosphamide and the rituximab have similar efficacy as an infliximab. And questions to ponder on is, can it still be a SPMS? But even though there is a dissemination in space and dissemination in time, there are odd points in form of nodular enhancement and the perivascular involvement. And so possibility of vasculitis is more. If it is a vasculitis, which type of vasculitis are we considering? In view of small vessel as well as a large vessel involvement, we consider the possibility of neurovasculitis and the neurosarcoidosis because of the subpile and the nodular enhancement. And could it still be a genetic disease with periodic worsening? Less likely, because with one immunosuppressive therapy, there is a worsening of the lesions. With the other immunotherapy, there is a drastic improvement in lesions, and progressive relapsing and remitting nature, so may not be a genetic disease. And the PET showing large vessel uptake is the only angle to consider vasculitis. Could it be false positive? May not be, because in a young male with a FDG avid uptake in a large vessels is suggestive for the vasculitis. And limitations in this study is MR angio and vessel wall imaging were not done. As the PET showed vessel wall uptake, it was treated as a vasculitis. And tissue diagnosis could not be done as the lesion size was very small and yield of the diagnosis was very doubtful. So take-home message from this study is MS is a diagnosis of exclusion. McDonald's 2024 criteria is to increase the sensitivity of the diagnosis of multiple sclerosis, but care must be taken to prevent the misdiagnosis. And the natalizumab worsening the disease activity, we need to reconsider the diagnosis before telling it as a progressive MS or a complication of natalizumab. And the neurosarcoidosis and the vasculitis can both mimic the multiple sclerosis closely. So PET-CT has been instrumental in clinching the diagnosis in this case. SWI adds to the diagnosis. So if there is an invasive test is not possible, we can go ahead with the PET-CT and the SWI. Thank you, sir. I would like to thank Dr. Sharat Kumar, sir. We have learned so many points, sir. Thank you. And I would acknowledge Professor Ravi Verma, sir, who always helps for our cases, and Dr. Madhu, sir, from the Nuclear Medicine HOD, and the patient and his families, and the Department of Neurology and the Radiology in NIMS. And thank you.
An excellent presentation, right? And a discussion also. I think when we consider all the ways in which MS is diagnosed, we always remember dissemination space and dissemination time. But the most important caveat is exclusion of all the mimics or the other possibilities. And I think she has very well discussed everything.
Thank you, Dr. Chamanti. Thank you, Shruti Madam and Sharat Sir, for this excellent discussion. Thank you, Reshma, for providing this case to us. For want of time, I think we would like to go ahead with the next case. So I invite Dr. Sharat Kumar sir to please take over now.
Sure, ma'am. Sure. Thank you. At the outset, I thank both Dr. Josna and Dr. Saraswati for giving this opportunity to be the part of this learning experience for me as well. So, without wasting much time, I request the moderators for the second and third topic, that is Dr. Ravi Prakash Singh and Dr. Akanksha from the Sri Institute of Sri Arbindo Institute of Medical Science, Indore, a beautiful city. And I request him to take over the session and ask his presenter, Dr. Ripple, to present both the cases simultaneously, and we can take the discussion forward after that. Dr. Ravi, please take over.
Good afternoon, everyone. Thank you, Saraswati Madam and IIN team for giving us the opportunity to present in this forum. So we have two interesting cases to discuss today. But the first case highlights the importance of clinical localization and pattern recognition in neurology. So I would like to invite Dr. Ripple, who is the final year neurology resident in our institute, so to present the first case.
Good afternoon, respected faculty members, seniors, and my colleagues. Thank you for this opportunity. I'm going to speak about a case of a rapidly progressive multifocal neurological syndrome in a young woman. A 41-year-old right-handed female 12th pass resident of Indore presented to us with chief complaints of numbness and weakness in both lower limbs since 6 months, diminution of vision and hearing since 2 months, facial weakness and difficulty in swallowing since 1 month, and headache for last 10 days. The patient was apparently all right. The patient was apparently asymptomatic 6 months prior to the presentation when she first noticed numbness in the sole of left foot, followed by similar symptoms in the right foot about 1 month later. Over the next 2 to 3 weeks, the symptoms gradually progressed to involve the dorsum of both feet and subsequently ascended up to the left knee and right hip. She reported reduced awareness of ground contact such that her slippers would often slip off without awareness. Over the following weeks, she developed imbalance while walking, describing it as a sensation of a swollen foot and as though she was walking on a cotton bed. The imbalance was more pronounced in the dark, particularly noticeable when going to the washroom at night. There was no history of burning sensation, electric shock-like sensations, but she complained of low back pain, which was non-radiating. During the same period, she found difficulty clearing the ground while walking, with her toes gliding over the floor, which was more noticeable on the right side. It progressed over the next month to difficulty in climbing stairs and requiring support to rise from the squatting position. Her weakness worsened further over the next month, leading to stop performing household activities and eventually requiring the assistance of 2 persons to get her from the chair. By the time of presentation to us, that is 5 months into the illness, her weakness had progressed to the loss of independent ambulation. She became dependent for activities of daily living, requiring assistance even to sit and stand. However, she had no difficulty in feeding herself, picking objects, or making her bread, or doing overhead activities. There was no fluctuations or diurnal variations in the weakness, and there was no history of muscle pain, cramps, thinning, or fasciculations. 2 months prior to the presentation, she developed painless progressive diminution of vision, which was initially noticing difficulty in seeing the clock, which progressed over 2 months to the extent that she could recognize objects only when close to her face with the right eye, while she was able to perceive only light with the left eye. There was no history of diplopia, flashes, or floaters. Around the same time, she also developed progressive hearing difficulty, such that she could hear only when spoken loud near the ear, and she herself had started speaking loudly. She reported that although she could hear sounds, she had increasing difficulty understanding the spoken words, and she denies the sounds being uncomfortable or unbearable even if spoken loudly. The hearing difficulty was bilateral, progressive, and was not associated with any ear pain, discharge, or vertigo. There was history of single episode of loss of consciousness about 2 months prior to presentation, with posturing of limbs without any tongue bite, frothing, or urinary incontinence. Over the last 1 month, she developed facial weakness with difficulty in chewing, rinsing the mouth, and inability to close eyes during sleep. She also developed difficulty in swallowing, particularly for liquids, though denied any associated choking or nasal regurgitation. There was no history of throat pain or preceding febrile illness. 10 days prior to admission, she developed a severe continuous holocranial headache associated with occasional nausea, vomiting, and neck pain without any diurnal or postural variation. And on further inquiry, she reported of having intermittent episodes of headache over the past 6 months, which were self-limiting. There was no history of fever, altered sensorium, behavioral changes, or cognitive decline. There was no bowel or bladder involvement, and no history of abnormal sweating or palpitations. There was no history of irregular menstrual cycles, lower abdominal fullness, and no systemic history of chronic cough, shortness of breath, chest pain, hemoptysis, or night sweats. There was a significant history of marked weight loss over last 3 months. There was no history of photosensitivity, joint pain, oral or genital ulcers, or Zika symptoms. She denied the use of alcohol or any history of toxin exposure or any long-term medication use. There is no history of any chronic illness. Patient consumes mixed diet and had normal sleep, but reports of reduced appetite, bowel and bladder habits were normal. She is a chronic tobacco chewer, and there is no history of promiscuous behavior. Her last menstrual period was 5 months ago, with non-significant obstetric and significant or any significant family history of similar illness. To summarize, a 41-year-old female presented with insidious onset of gradually progressive illness over 6 months with rapid worsening in the last 1 month, to begin with asymmetrical lower limb sensory symptoms with sensory ataxia, followed by progressive distal and proximal lower limb weakness leading to loss of ambulation, and later development of painless visual impairment, hearing difficulty, bilateral facial weakness, and bulbar symptoms, along with an episode suggestive of seizure and recent headache with vomiting. There is no bowel bladder involvement or cognitive decline, and the illness is associated with significant weight loss.
Thank you, Dr. Ripple, for the detailed history. I would like to open it to the audience if they have any further question they would like to ask in the history. Otherwise, we would proceed with the localization and approach, how to approach the history.
I think we'll proceed with the localization.
Yeah, it's a very complex localization here.
Yes, ma'am. Yes, ma'am. Thank you, ma'am. To localize the initial symptoms of ascending progression of weakness points towards the large fiber peripheral neuropathy, and the severe sensory ataxia points towards sensory neuronopathy. But overall, the asymmetrical picture of non-lens dependent sensory symptoms, along with associated distal and proximal weakness with patchy involvement, points more to polyradiculopathy. Although there was classical dermatomal pain was absent in this case. Similarly, the weakness both in proximal and distal distribution with asymmetrical and patchy involvement points towards polyradiculopathy. The simultaneous involvement of multiple cranial nerves, along with the history of headache and vomiting with preserved consciousness and without any long track signs, points towards the involvement of an extraaxial process, likely the subarachnoid space. The whole process suggests the involvement of cranial nerve diffusely rather than the involvement of a focal lesion.
Would you consider spinal cord here for the lower limb weakness and sensory problems?
I'm considering the root involvement at the spinal level, ma'am.
I agree that in any patient who presents only with lower limb symptoms without upper limb, you would consider roots, and the second thing you would consider is a dorsal cord. Why not dorsal cord here?
Ma'am, since the involvement had no long tract signs or any pyramidal involvement, also there was no bladder involvement,
Excellent.
and this points against the involvement of cord. And weakness was also, ma'am, not in a fashion. It was patchy involvement over proximal and distal simultaneously.
Yeah. So that we would like to examine and confirm. But the main point I would also agree is the bladder bubble is not affected in spite of a very severe lower limb weakness.
Yes, ma'am.
Thank you.
The presence of headache and vomiting would also be localized to meningeal or subarachnoid space. The signs of the other possibilities could be due to signs of raised intracranial pressure, but there was no symptoms of altered sensorium, no focal symptoms, or any postural variation. Also, simultaneous presence of so many cranial nerves does not explain the raised ICP syndromes. The third possibility of the space occupying lesion in the brain parenchyma was also considered, but since there was no focal symptoms and the involvement of radicular involvement in the lower limbs does not get explained with the brain parenchymal involvement. One episode of seizure could be the cortical irritation secondary due to leptomeningeal involvement. So the probable neuroanatomical structures after the history were considered at nerve roots, cranial nerves, meninges, plus minus cortex, which all can be localized to a subarachnoid space as an extraaxial process, as subarachnoid space contains the cranial nerves, spinal nerve roots, CSF pathways, and is continuous across the entire neuroaxis. So the whole process can be a leptomeningeal disease with arachnodiasis. The clinical picture is best explained by a diffuse extraaxial process involving the subarachnoid space, leading to polyradiculopathy and multiple cranial nerve involvement with possible secondary cortical irritation, which is consistent with a leptomeningeal involvement.
Shall we proceed, or any questions or clarifications are there?
I think we can proceed, for time is a problem. We can
Okay,
finish
sure.
the first round.
The etiological diagnosis, the first possibility of chronic infection was kept. Tubercular meningitis being endemic in India, and along with the history of multiple cranial involvement with signs of chronic meningitis, was a possible etiology. But marked radiculopathy features, no history of fever, and no history of TB focus points against towards tubercular meningitis. The triad of chronic meningitis, cranial neuropathies, and radiculopathies points in favor towards the Lyme's disease, but there was no history of any flu-like symptoms, rash, or any other systemic involvement. Meningitis, sensory ataxia, and cranial nerve involvements can be a favoring point for neurosyphilis, but there are no risk factors and there is no significant pain in the lower limbs or any history of vasculitic like events like TIA or strokes. Second possibilities were considered for the systemic malignancies, first being the carcinomatous meningitis, owing to the diffuse cranial and root involvement with the history of headache, vomiting, and rapid progression, along with the constitutional symptoms of weight loss. But there was no history of malignancy in the history. Secondly, neurolymphomatosis can be considered with similar presentation, but there was no painful swelling, and peripheral neuropathy is more common than root involvement in neurolymphomatosis. The third possibility of paraneoplastic syndrome, neurological syndrome, was also considered initially, owing to the multifocal neuroaxis involvement with special emphasis on NT-HU and CRMP5 antibodies. But those present with multiple neuropathies along with the features of encephalomyelitis, which was not in our case. Also, paraneoplastic neurological syndrome is more of a systemic involvement involving dorsal root ganglia or cerebellar process, but rather than a diffuse process like this one. We also wanted to rule out neurosarcoidosis with points in favor being multiple cranial neuropathies, root involvement, and sensory motor symptoms in lower limbs on background of headache and an episode of seizure. But there was no systemic feature, no respiratory symptoms, and isolated neurosarcoidosis is a rare entity overall. IgG4 disease was also considered with the headache and cranial nerve possibilities, but there was no systemic signs and symptoms pertaining to it.
So there are a few things here.
Yes, ma'am.
Yeah, so of all the things you discussed, which one would you give the highest priority? It's very beautifully discussed. But in
Ma'am,
this patient,
yes, ma'am. Ma'am, the systemic malignancies would be the first possibility, considering the carcinomatous meningitis and paraneoplastic neurological syndrome because of the involvement of multiple neuroaxes.
that can
Also,
occur with TB as well, right? But why in this patient would you consider a carcinomatous?
ma'am, there was no history of fever during the entire course of illness.
Agreed. Yeah. The patient is relatively well preserved and otherwise
And
cognitively and everything.
yes, ma'am. And also in TBM, patient with such an extent, the patient would end up in altered sensorium, decreased cognition, and won't be in such a stable cognitive condition.
Correct. So the patient, a relatively preserved patient, but with very extensive multifocal involvement would make us consider carcinomatous or even neural lymphomatosis more than an infectious possibility. And I like the diagnosis of paraneoplastic, although I think it is not a very nice one to explain the headache and all. It can explain tract involvement or anterior onset involvement at specific levels, can explain why only certain tracts are affected. But in general, it will involve both upper and lower limbs. There is no preference for one side alone. So if there is marked involvement of lower limbs, you would also find some upper limb involvement. Are there any questions? Let me see. The question is, are there any systemic symptoms at all? I think you mentioned weight loss, right?
Yes, ma'am. Significant weight loss of 25 kgs in last 3 months, ma'am.
Anything else?
Ma'am, there was loss of appetite also. And the last menses was 5 months ago. After that, she did not have her menstrual cycle.
Okay. She was pregnant, you told her? Or-
No, ma'am.
Okay, no.
ma'am.
It was Ranjit. Okay, fine. So Dr. Ravi, shall we?
Yes, ma'am. Can we continue with the examination, madam?
Yes, please.
Okay, sure.
Thank you, ma'am. On examination, patient was conscious, alert, and was good to obey the command. And there was no pallar icterus cyanosis. The faces was puffy with coarse bared feces and acanthosis and hyperpigmentation over the skin. There was palpable lymphadenopathy in cervical and bilateral axillary regions with no skeletal deformities. Her vitals were stable. On local examination, we found lump over the upper outer quadrant of right breast. The higher mental function examination came out to be MMSE of 20/30. The speech was loud with flaccid dysarthria and nasal intonation.
धीरे धीरे चल नहीं पा रही मतलब चल ही रही होती है ना भाव ना बिल्कुल भी वजन नहीं संभाल पाते हैं और फिर दूसरी बात कि मेरे हाथ पैर तो पूरा शरीर ऐसा लगता है जैसे
In cranial nerve examination, the first cranial nerve was normal. The visual acuity was reduced to perception of light bilaterally. Color vision could not be tested. The pupils were bilaterally 3 mm sluggishly reacted to light, and fundus showed bilateral optic atrophy. There was bilateral ptosis, left more than right. with impaired adduction and elevation of the right eye, as this can be seen in the pictures, with impaired abduction of the left eye, along with restricted elevation of the left eye and impaired downgaze of right eye, which supports the multifocal oculomotor dysfunction. Nystagmus was absent. Patient complained of reduced sensation over the left half of face and had bilateral element facial weakness with decreased forehead wrinkling, incomplete eye closures, and with flattened nasolabial folds.
दोनों आंख बंद करके दिखाओ, एकदम जोर से आंख बंद करके दिखाओ, और जोर से।
In the 8th cranial examination, the air conduction was better than bone conduction, but since the patient had reduced hearing bilaterally, Weber's could not be lateralized. The palatal movements were reduced bilaterally with midline uvula, and the gag reflex was diminished bilaterally. The voice had nasal intonation. 11th cranial, the tongue was weak bilaterally and with midline protrusion. The motor examination revealed normal power examination in the upper limb, while there was marked asymmetry in the lower limb power with both proximal and distal limb weakness. The DTRs were present in the upper limbs and they were absent both knee and ankle joint in the lower limbs. The superficial reflexes were present and plantars were bilateral mute. In sensory examination, crude touch and temperature was normal. Fine touch, joint position, and vibration was impaired in both lower limbs. There were no cerebellar signs. As you can see in this video, patient was able to do the fingertips, and there was no dysgynecokinesia. The gait examination was limited, and there was normal skull and spine examination. So the added findings after examinations are the pigmentation over the skin, breast lump and lymph nodes, multiple cranial neuropathies including bilateral 2nd, 3rd, 7th, 8th, 9th, 10th and 12th, and left 6th cranial nerve with absent deep tendon reflexes in lower limbs, large fiber sensory loss in lower limbs, and proximal and distal lower limb weakness.
I think your examination is excellent, excellently shown on many things. I think it has ruled out a human involvement completely, because the reflexes are reduced and the cranial nerves are involved bilaterally without any long track signs.
Yes, ma'am.
So the weakness, of course, is element.
Yeah.
So this is so for the visual problem, there was no papilledema, you told, no?
No, ma'am. There was optic atrophy, and by the time she presented to us, it was secondary optic atrophy.
Okay. And she had any features of meningeal irritation per se?
Sorry, ma'am.
Was there any features of meningeal involvement? Any sign positive?
She had headache only, ma'am.
No, clinically examination-wise, was there a neck stiffness or a Kernicks positive or anything?
No, ma'am. No Kernicks positive. No neck stiffness. Only headache, ma'am. Yes, no signs.
Okay. So please proceed with the differential diagnosis.
So the differentials which were considered after examination, most likely carcinomatous meningitis, paraneoplastic neurological syndrome, tubercular meningitis, neurolymphomatosis, or neurosarcoidosis. On investigations, the routine blood profile was within normal limits and patient was subjected for MRI. The T1 axial post-contrast images here is suggestive of diffuse contrast enhancement in the paracisternal regions over the sulcal spaces in the along the optic nerve sheath and optic chiasma with multiple cranial nerve enhancement. The T1 spine sagittal MRI in second image, as we can see, was suggestive of multiple T1 hypointense lesions in the dorsolumbar vertebrae. In the T1 post-contrast images, as we can see in the third and fourth images, there was subtle contrast enhancement over the cervical roots and diffuse enlargement over the lumbosacral roots suggestive of arachnoiditis, along with the contrast enhancing lesions in the dorsolumbar vertebrae, could be possibly the lytic bony lesions. This overall picture pointed in favor of carcinomatous leptomeningitis, which is very clear through MRI picture of cerebellar and sulcal involvement along with the root involvement at the level of spine. There's a classical Bloomy-Ringe sign which can be seen in the patients with leptomeningeal carcinomatosis, which can be seen in the FLAIR images along with the diffusion restriction and ADC reversal in the anterior and lateral brainstem regions without any contrast enhancement. But this was not seen in our patient, and as we can see, the FLAIR was grossly normal in our patient. Instead, it shows the post-contrast FLAIR enhancement.
Can you go back? I will just summarize the imaging findings so that for the benefit of others.
Yes.
Yeah, you can stop at this level. So in these images, usually we always recommend post-contrast FLAIR in all the leptomeningeal pathologies. It adds a lot of values as compared to only conventional post-contrast T1 weighted fat suppressed images. So always try to include in any meningeal pathology. So there is one point, and you can see already hydrocephalus has set in. You can see the temporal horns are ballooning out. And this there is a diffuse leptomeningeal process going on, including the cranial nerves. Everywhere the post-contrast images are showing plastering of the cells and enhancement. If you go to the next slide, because there are so many pathologies which can cause this diffuse not that one, the previous one, yeah. The one clinching which I use for my day-to-day practice to separate it from other basal meningitis from the leptomeningeal carcinomatosis is the third image. You can see the third image. There is characteristic glaring enhancement in the superior cerebellar folial spaces below the tent. If you see the third picture. So this is very, very characteristic and very favorite site for the leptomeningeal carcinomatosis. Probably this is due to CSF dynamics in the posterior fossa, which dependent pooling along this superior cerebellar folia, followed by this basal cisterns, gives this classical appearance of leptomeningeal. Whenever we see that everywhere there is enhancement, but characteristically more enhancement is seen in the below the tent. We always suspect leptomeningeal carcinomatosis. One of the practical clues, which is not mentioned in books, but we consistently see and have diagnosed so many cases based on this. And coming to the next slide, if you show that Bloomy-Ringe sign, Bloomy-Ringe sign is nothing but a subtype of leptomeningeal carcinomatosis, which texts say that it's classical to EGFR mutation associated adenocarcinomas of the lung. Here in this case, it's only restricted to this basal cisterns, especially around the midbrain and the pons, where you would see a rim of hyperintensity coating along the brainstem. And generally, it is only limited to that rather than the superior cerebellar folial spaces or diffuse leptomeningeal, like in your case. And they always say it is often associated with CL lung rather than any other pathologies. So whenever we see only Bloomy-Ringe, we always screen the chest. So for the EGFR mutant, very, very specific, though not sensitive, very, very specific. In our case, it was not a CL lung. That's why we could see everywhere the leptomeningeal process, not restricted to. When it is restricted to this area, giving then it is more classical of Bloomy-Ringe sign of CL lung, that to adenocarcinoma EGFR mutation associated. So that's the take-home message. Always look at the posterior fossa, superior cerebellar folial spaces.
Yes.
Next, you can go ahead. Go ahead.
Sir, thank you, sir, for your guidance, sir.
There is a single query from the panel. Platelet count, is it very high in this patient?
5.46.
Yes, ma'am. She had
5.4. 5.46, madam.
Okay. So you have any take on that? As a hematological malignancy, we usually expect it to come down.
we ruled out anemia also, ma'am, when that
Yeah,
patient
yeah. So,
iron and everything was within normal limits, ma'am.
yeah, it could actually come even with other malignancies. Actually, it's more common with solid malignancies than with hematological malignancies. So for hematology malignancies, they tend to go down, and for there can be a paraneoplastic thrombocytosis or even otherwise thrombocytosis can occur with solid tumors.
Yes.
Yes, ma'am. Thank you, ma'am. After MRI, we proceed with the CSF examination, and CSF was consistent with high protein and normal to low glucose with cell count of 55 and area of 8 with opening pressure of 18 centimeters of water. CSF TB-PCR was negative and CSF for atypical cells was negative. We called patient for repeat CSF examination, but patient did not give consent for the same. Serum protein electrophoresis and urine for Bence-Jones protein was negative. HLA-B51 was negative and serum ACE level was also normal. This was the NCV of the patient, which was suggestive of absent CMAPs in the lower limb with normal SNAPs overall, suggestive of lower limb predominant neuropathy, motor neuropathy. This was the mammogram and USG breast of the patient, which is suggestive of Birad's grade 4 right breast lesion along with axillary lymph nodes and bilateral axilla. The biopsy was sent, which was suggestive of invasive lobular carcinoma of grade 1. Patient was then subjected to PET-CT, which revealed the right breast lesion as primary, along with the FDG-avid right pleural thinking bilateral lung nodules, bilateral adenal and lytic skeletal lesions as metastatic. We also sent the paraneoplastic panel for the patient, which came out to be borderline positive for anti-ZIC4 antibody. Though this antibody is known to be associated with small cell lung carcinoma, and the phenotype associated with these antibodies are the sensory neuronopathy and paraneoplastic cerebellar degeneration. However, this phenotype of carcinomatous meningitis, whether it is associated with these antibodies or not, we need to review the literature further. So the final diagnosis of a case of diffuse leptomeningeal metastasis presenting as polyradiculopathy with multiple cranial nerves involvement secondary to metastatic invasive lobular carcinoma of the breast was made.
It's a great case. I would say that since the diagnosis is not a paraneoplastic syndrome,
Yes, ma'am.
The presence of an antibody does not contribute much to the diagnosis here.
Yes,
Sure.
ma'am.
Here we have shown that it is due to the infiltration of the tumor cells. There are some questions. One is Anita madam is asking what is the specificity for EGFR for the blue mirror sign.
Yeah, literature doesn't say much about that because all the case reports are EGFR mutants malignancies which they have noticed, and the plausible theory is that EGFR mutant cells may upregulate aquaporin 4 expressions, and which causes this failure this aquaporin and then the cellular infiltration, inflammation. Because similar imaging findings have been also noted in other cases. It's not as pathognomonic. Even NMOSD positive cases also similar ring type appearance. Even varicella has been reported. So probably it is related to this aquaporin 4 upregulation is a possible explanation, but nobody knows the definitive answer for this.
Thank you. There is also a comment that it could be thrombocytosis could be related to a myelodysplastic syndrome. Yes, and the point that the SNAPs are normal in nerve conduction studies, indicating that this is a preganglionic, which is your primary localization also. You have localized it to a polyradiculopathy.
Yes, ma'am.
And Dr. Ishma has asked about the cell-based assay. Is it available for paraneoplastic?
No, ma'am. We did not go for that.
We don't have access to it, cell-based assay for this one. Okay, madam has also responded no. Anita madam has also responded no.
Thank you, madam, for your inputs.
Right. I think you can go into the discussion now.
Yes, ma'am. And Patient was initially started on empirical ATT and steroids, but after the above investigations, we stopped ATT and patient was continued on steroids. Oncology team was involved for further management, but she had no improvement with the steroids. Patient was planned for repeat CSF examination, but lost to follow-up after 1 month. The leptomeningeal carcinomatosis is the involvement of subarachnoid space and can be seen in 5 to 8% of solid tumors like breast carcinoma, followed by lung carcinoma and melanoma. It usually spreads via hematogenous route or direct expansion or extension of the tumor cells into the meninges. The most common sites of predilection are the basal cisterns, posterior fossa, including the cerebellum, and the quadra equina. The pathophysiology of symptoms can be the CSF flow disruption leading to hydrocephalus, tumor increased complement C3 levels leading to blood-brain barrier breakdown, and VEGF-mediated angiogenesis, all which can lead to multifocal neurodeficits as a hallmark of the disease, which can be seen as a headache, seizures, facial multiple cranial nerve palsies, limb weakness, sensory loss, radicular pain, along with nausea, vomiting, and headache. Some vascular complications like infarcts can also be seen. The red flags in the cancer patient, if there are the new multifocal deficits along with the cranial nerve and radicular involvement together with persistent headache, this should be kept in mind. The survival of this patient is 4 to 6 weeks if left untreated, and it's only 2 to 4 months when treated. And survival also depends on the KPS score, with favorable factors being KPS score of more than 70, normal CSF flow, minimal neurological deficits, chemosensitive primary tumor, and CSF protein of less than 50. The poor prognostic indicators are KPS score of less than 60 with signs of encephalopathy, extensive CNS or systemic disease, and severe neurological impairment. So the take-home points are: think in compartments, not just symptoms. Seemingly multifocal neurological deficits can be explained by a single anatomical space. Subarachnoid space involvement can unify cranial nerves, nerve roots, and meninges. Secondly, cranial plus radicular is the red flag pattern with the combination of multiple cranial neuropathies and polyradicular neuropathy, strongly suggestive of leptomeningeal pathology rather than isolated peripheral or central nervous system disease. In an unexplained multiple neuroaxis syndrome like in a country like India, where tubercular meningitis is common, it is important to obtain extensive history and vigilant examination in order to differentiate it from other systemic malignancies. Not all areflexia is CIDP or GBS. Areflexia with weakness is not synonymous with peripheral neuropathy. Always look for associated CNS or meningeal features before labeling.
Thank you. Did you find anything in the CSF cells, any malignant cells there?
Ma'am, we did the first CSF for atypical cells, which came to be negative, and we wanted to do repeated CSF examination, which would have increased our yield of atypical cells, but patient denied and did not give consent for the same, ma'am.
Yeah. And anyway, you found the primary as well, so that is
Yes,
not a
ma'am.
big concern. Thank you. Excellent case. I'll give it to Dr. Ravi to decide any further questions are required.
Yes, thank you, madam. So we conclude with the first case. Now we move on to the second case, which is a relatively short case. And this case actually highlights that we should be very aggressive in treating autoimmune encephalitis patients, particularly the young ones. So I will hand over to Ripple to present the case.
Thank you, sir. The second case is from akinetic mutism to recovery, dramatic outcome despite the delayed treatment. A 20-year-old right-handed male student from Rajgarh presented with history of fever 5 months ago, behavioral changes since 4 months, slowness of activities of daily living since 4 months, and changes in sleep pattern since 3 months. 20 days after the onset of fever, the patient developed behavioral changes, which was in the form of progressive social withdrawal with reduced interaction with the family members. He would stay mute for whole day and with no limb movements and no speech or sound production would confine to bed. There was loss of initiation. Patient would stop asking for food and water. However, when being fed, he would eat normally and in similar quantity that he used to eat earlier. Over the next few days, he started urinating and defecating in clothes and would not tell anyone about urinating in clothes and remained indifferent to it. There was no history of any aggressive or abnormal behavior or any history of inappropriate dressing. Over the past 3 months, the patient was noted to have a progressive slowing in activities of daily living in form of reduced speech output, slowness in walking pattern, difficulty initiating movements such as getting up from bed. There was no history of any other involuntary movements. Relatives reported severe insomnia, with the patient remaining awake for several consecutive days, and he would lie awake with staring gaze. However, there was no history of hallucinations, seizures, sleepwalking, RBD, or reversal of the sleep wave cycle. Overall, the symptoms of behavioral arrest and mutism fitted into the phenotype of akinetic mutism. The akinetic mutism, along with the lack of initiation and severe insomnia, points towards the involvement of limbic system and frontal subcortical circuits. Interestingly, the patient had preserved motor functions and there was no seizures. However, possibility of subclinical seizures or non-convulsive status epilepticus needs to be ruled out further. The symptoms were localized to the bilateral limbic system involving the frontolimbic disconnection. Based on the constellation of symptoms as apathy with mutism, sleep disturbances, and psychomotor slowing, syndromic diagnosis of subacute onset encephalopathy with akinetic mutism phenotype was made. After ruling out all the metabolic causes of such presentation, with limbic predilection, we kept the possibility of viral encephalitis, but the course of illness was against the same. Second possibility of autoimmune encephalitis was considered with the rapid progression of neuropsychiatric symptoms along with sleep disturbances, but there was no history of seizures. Third possibility of primary psychiatric disorders like catatonia was considered. As we can see in this video, this was the video at presentation. When patient would lie on bed with staring look, he would make only neck movements on being called. He made good eye contact, but was slow to respond and had normal facial expressions.
ये बताओ ये कौन है? अलका, तुम अभी कहाँ हो? बता पाओगे? तुम कहाँ हो अभी? बताओ ना क्या बोल रहे? बोलो.
This was the video when he
बोलो
presented
अलका.
to us.
कर चले. तो सबके पूछ रहे, बताओ ना उनसे.
Now we can see after being
अच्छा,
given
अलका, उठ
command,
जाओ.
patient would
कुर्सी से
follow
उठ
it
जाओ.
slowly and he will stand
बैठ जाओ.
and he will start walking,
ठीक है, जाओ अपने पलंग तक
but
जाओ.
had been
कहाँ है
mute
तुम्हारा
throughout
पलंग?
the examination. On further examination, patient was inattentive and remained indifferent to everything what was being asked to him. So the examination was all limited. Patient would not even answer the questions of registration and recall, but was conscious, but not oriented and attentive to follow any instructions. In gross motor examination, the positive findings which we got was the generalized rigidity, truncal bradykinesia. He was slow to walk and had reduced arm swaying, but had no ataxia. He would grimace to pain on the examination. On routine blood investigations, we found the raised count of 16,000. Rest of the examination, including the metabolic parameters, were within normal limit. The CSF routine examination was suggestive of normal picture with normal protein and glucose with cell count of only 2. This was the MRI of patient at presentation, which is normal and is not suggestive of any hyperintensities in the medial temporal regions. Since he had no seizures, still considering the possibility of subclinical seizures, EEG was done, but it was normal. Most probable differentials after examination and investigations were viral encephalitis versus autoimmune encephalitis. CSF HSV PCR was sent, which later came to be negative. Autoimmune encephalitis panel was also sent, and patient was started on IV pulse steroids, antibiotics, and acyclovir. While reports were awaited, patient had minimal improvement in symptoms, but he went LAMA, and despite of further treatment plan being discussed with the patient.
Can we
After-
discuss at this point?
Yes, ma'am.
Yeah. So this is a very, very unique presentation. No? How did you differentiate this from a psychiatric problem?
Ma'am, there was a preceding history of fever 5 months ago, and then patient had neuropsychiatric symptoms, and there was no posturing of limbs, um, uh, no psychiatric symptoms in form of the patient had been following commands, but had no indifference to surroundings.
So there
Actually,
are no
ma'am,
affect
there was,
changes
to
also.
start with, patient had developed rapidly worsening symptoms, madam. I mean, 5 months back when the symptoms started, he had rapid worsening. Within 10 days, he became mute and very slow. And thereafter also, when the new symptoms came, the symptoms came within 3 months. After that, he was relatively static. He was taking multiple medications from Ayurvedic practitioners, and antipsychotic medications also were being prescribed to him, but he did not have any improvement. The symptoms actually started very rapidly and became static after 3 months. So he came to us after 5 months.
I fully agree with your diagnosis itself. The thing is that there is no catatony. Usually at this point, if the psychiatric patients behave like this, they are catatonic.
Yes, ma'am.
That you have clearly shown, told in examination, it does not exist. And even if it looks like a primary psychiatric, even if it is a primary psychiatric, this kind of rapid presentation should make us wonder whether it is an organic pathology rather than a primary psychiatric problem.
Yes,
So I
madam.
fully-
Even till 5 months, he did not receive any, treatment. I mean, he was only taking OPD treatment from the psychiatry, from psychiatry team. So when he presented to us, we strongly considered, something organic, because these patients, they do recover and they have a very good prognosis if we treat them well.
Correct.
So that's why we immediately went on to investigate extensively, and we did the HSV PCR and autoimmune encephalitis panel, and we started him on steroids, antibiotics, and acyclovir empirically, because already time was lost. So he had very minimal improvement with steroids, and the slowness somewhat improved. He started speaking a bit, but still the symptoms were only, we can say 10 to 20% improvement was there. So further treatment plan was there to decide. I mean, after the CSF autoimmune encephalitis panel, but the patient got discharged. So while we were awaiting the reports, then he went LAMA.
And the presence of the extrapyramidal symptomatology, that would have helped also to say it is organic. And in addition, the incontinence, as one of our audience has also told.
Yes,
and but the problem was that he was on a higher dose of antipsychotics at the time, no?
Yes,
Yes,
madam.
Yeah. And could I request Dr. Sharath also to comment normal MRI versus an abnormal MRI to differentiate between autoimmune and viral encephalitis?
Yeah. Usually, the imaging is most of the time normal in most of the autoimmune encephalitis, especially limbic versus non-limbic patterns. There is no, regarding viral encephalitis, the consistent finding is the restricted diffusion. The chiral restricted diffusion, which is very, very uncommon in autoimmune encephalitis as compared to the viral infections, because there are only few subsets of autoimmune diseases like antima to antibody disease. Those are the one which show restricted diffusion. Otherwise, more than 90% of all the autoimmune encephalitis do not show characteristic restricted diffusion like a viral encephalitis, especially HHV. Both herpes as well as HHV6 can show restricted diffusion, or any other viral encephalitis. And also, hemorrhage, if it is there, then obviously hemorrhagic viral encephalitis is easy, which is uncommon for autoimmune encephalitis. Another one is enhancement pattern. Usually, we do not give contrast in most of the cases, but if we give most of the autoimmune encephalitis, again, autoimmune disease which involves brainstem can show enhancement. Apart from that, most of the autoimmune encephalitis do not show enhancement as well. So this is how I see in the patterns between viral and autoimmune, whether they are showing characteristic restricted diffusion and enhancement and plus or minus blooming. So these 3 points help us, because most of the time we don't give contrast unless we have any other differentials.
Thank you. And we also see that when it is normal, it is much more likely to be an autoimmune rather than
Autoimmune,
a.
yes, ma'am. Yeah,
Yeah, yeah.
that.
And you can have similar kinetic mutism with thalamic involvement as well in addition, but there they usually have drowsiness and depressant. Sorry. There is a question. In this chronic case, why was HSV encephalitis considered? Can normal MRI occur with chronic HSV encephalitis?
Yes, madam, it is usually, it's definitely odd, but HSV can present subacutely or can evolve over time also. I mean, it may show a prolonged course, especially
Only
partial.
thing-
Sometimes outside also, they may not be able to tell that whether they have received treatment or not, but sometimes people, they do give antibiotics. So that's why, I mean, we thought of that thing also.
And
It's
you had
very
stopped
uncommon that,
worsening.
yeah, ma'am, it's uncommon to have that imaging is completely normal. We have seen acute, subacute, chronic granulomatous herpes encephalitis also, but almost all of them show some signal changes. Absolutely clean MRI, very, very likely.
Yes.
Okay, sir.
Thank you. Shall we move on then?
Yes. Yes. The CSF autoimmune encephalitis profile came after 1 week, which was positive for GABA B receptor antibody. So the patient was immediately called back and he was readmitted. He was immediately started on plasmapheresis, even though he had delayed presentation. CECT chest and abdomen was done to rule out paraneoplastic association, and this was normal. Relatives were counseled about the need of PET-CT, but they did not agree, which was done later. Now, during this episode, patient was found to have episodes of behavioral arrest and staring look, which responded well to benzodiazepines. During the cycles of plasmapheresis, there was improvement in the clinical condition. And after the completion of 5 cycles of plasmapheresis, he had marked improvement in sleep and speech, but signs of apathy was still noted. And therefore, long-term immunomodulation with rituximab was planned. This is the video after the 3 cycles of plasmapheresis.
कहाँ के रहने वाले हो तुम? अच्छा, पिताजी का नाम और मम्मी का नाम? कितने भाई है तुम्हारे? काय की पढ़ाई कर रहे हो तुम अभी? नीट की पढ़ाई कर रहे हो? अच्छा, ठीक है। अभी कैसा लग रहा है तुमको? कैसा लग रहा है? ठीक है, ठीक है। एक बार बैठ के बता दो अलका, बैठ जाओ।
As we can see, the patient had started talking and is also following commands.
ठीक है, दोनों हाथ उठाओ अलका, दोनों हाथ उठाओ। बहुत बढ़िया, ठीक है।
And after receiving the 2 doses of rituximab, this is the video of this patient after 1 night.
पापा का नाम रामचंद्र लैंगवे, माता का नाम लालीबाई लैंगवे। राजगीर जिले में रहता हूँ। नाम तो नहीं आ ग्राम बानपुरा का रहने वाला हूँ।
And patient has been on regular follow-up since then, and PET-CT was done in the current follow-up, which was suggestive of solitary pulmonary nodule in the right lung, likely mitotic lesion. The biopsy of the same has been sent, and the report is awaited. The final diagnosis of anti-GABA B receptor autoimmune encephalitis presenting as akinetic mutism phenotype was made.
An excellent case, and I think you have brought home many, many important points as well. Do you have a summary of that?
A
Okay.
summary, ma'am, it was a short
case, so we
did not put the summary.
No,
ma'am,
I
but,
think the point you mentioned that plasma exchange, even when done quite later, also should usually produces good improvement. especially if a lot of MRI changes have not occurred.
Yes, ma'am.
Yes, ma'am.
So, the autoimmune encephalitis is a rare disease with an incidence of 0.8 to 1 lakh person years. A prompt diagnosis and treatment lead to improvement or full recovery with steroids or immunomodulatory therapy, indicating an autoimmune cause even in the absence of confirmatory serology. It was first elicited by Leicester et al. That GABA the encephalitis and is a relatively rare disease that accounts for only 5% of cases of all autoimmune encephalitis. This young male presented to us very late after the onset of symptoms and was diagnosed to have autoimmune encephalitis of rare type, that is GABA B receptor autoantibodies, and he recovered completely with subsequent treatment. Autoimmune encephalitis results from antibody reactions to the neuronal surface of synaptic proteins and causes memory or behavioral problems and seizures. The typical symptoms of GABA B encephalitis are that of limbic encephalitis. The most common initial symptoms are that of seizures, followed by cognitive dysfunction and psychiatric abnormalities. And it has got strong association with small cell lung cancer in 50% of cases. Diagnosis can often be delayed due to variable presentation of the disease. As was seen in this case, the diagnosis was made 5 months after the initial sign and symptom. These are the case reports of the GABA B receptor encephalitis, in which the predominantly presentation was made with the seizures. And there are the other case reports in which we can see the out of 4 cases, 2 cases were there which presented with the neuropsychiatric features with the behavioral abnormalities and had no seizures. Recently, one article in the previous case series also, as we can see, the EEG was also reportedly normal in patients, and the patient's MRI was also normal, as was the case in our patient. The article which was published in Green Journal of Neurology was also suggestive on atypical presentation of GABA B encephalitis, in which patient was a 73-year-old female who presented with neuropsychiatric symptoms and had no history of seizures at the presentation. The take-home message: a subacute behavioral arrest with mutism, we must consider autoimmune encephalitis. Absence of overt seizures does not exclude autoimmune encephalitis. Akinetic mutism is a key but often overlooked presentation of limbic dysfunction. Neuroimaging may be normal in autoimmune encephalitis, but clinical suspicion must prevail. Always screen for malignancies, but its absence does not negate the diagnosis. Delayed presentation is not a contraindication. Timely immunotherapy can still yield meaningful recovery. Thank you, ma'am.
Thank you. I think we had wonderful 3 cases today. And very nicely, that discussion was also done. So there is in patients with sleep disturbances, extrapyramidal syndrome, and chronic presentations, Iglon 5. Yeah, that is a good point from Dr. Reshma. So in your case, I think the presentation was more in terms of mesial temporal frontal dysfunction. Yeah. And I think Dr. Elvira, she has raised her hand. Is there any specific question you would like to ask?
Hello. Very nice cases and very nice moderation, ma'am. I just had in the last case, I think we should go for a syndromic approach, as the presenter and the moderator have rightly said. With such a young patient, you would always go for a primary organic disease first rather than putting it as a psychiatric disease. But syndromically, this sort of presentation, the akinetic mutism. So, it is basically, I would put it as a syndrome of catalepsy. Catatonia is not a mandatory criteria. You have something called the Bush-Francis catatonia rating scale. And as rightly the presenter also said in the later slides that the patient had a very good response of with benzodiazepines during that akinetic mute state. So the lorazepam challenge test which is used to like you do the Bush-Francis scale before, and then you give a challenge with lorazepam and see if the patient improves. And if it is possible, get a simultaneous EEG recording, because if it is if it's like a short episodes of non-convulsive status, you can differentiate that response with the absence of an EEG correlate. Then it would go in favor of a diagnosis of catatonia or catalepsy. So in such a situation, of course, you have other differentials, like this patient has already been on several antipsychotic agents. So a differential of an extrapyramidal syndrome versus neuroleptic malignant syndrome and a catalepsy with secondary causes like autoimmune encephalitis. Autoimmune encephalitis these days is turning out to be one of the very important causes of secondary catalepsy. We often find, like, we get calls from the psychiatry wards with the patient being admitted as something like a catatonia, and then subsequently you find out that the patient has autoimmune. Similarly, recently we had a patient who had KLHL related autoimmune encephalitis, and during the hospital stay, the patient started developing this episodes of staring, and we did a lorazepam challenge test, and there was significant improvement. So I think this is a new phenomenology that we are experiencing, and I'm not sure whether GABA B has been previously reported to be associated with catatonia. If we can go through that, then this would be something which is worth reporting.
Thank you
Yes,
very much.
we are
Excellent
planning
points.
to, report it, because this kind of already in India, the cases of GABA B have been very, few cases have been reported, ma'am, and with this kind of presentation.
No, but I think catatonia is something which is like, I don't know, the benzodiazepine response. If you have a video recording of it, then it would be very valuable.
Actually, ma'am, the benzodiazepine response was that behavioral arrest episode that he had. While we were observing him in the ICU, and he had frequent episodes of behavioral arrest. So during that time, when we gave, it was not like he had rigidity at that time, because rigidity became quite normal. After 3 cycles of plasma exchange. But then we noticed behavioral arrest that happened to him, and when we gave him lorazepam, his sensorium improved.
You thought that was more in terms of a seizure.
Yeah, we were thinking more in terms of seizure, those episodes.
Yeah,
But
it is
again,
difficult to
EEG again
differentiate
was normal.
unless you have a corresponding EEG. If a corresponding EEG is normal, then that goes in favor of catatonia. And as I said, rigidity, paratonia, they are not necessary for making a diagnosis of catatonia or catalepsy. Associated this sort of mutism improving with the lack of EEG correlate, presence of tachycardia and other autonomic abnormalities. So there are several criteria that are in that list, and commonly we tend to think that if there is increased tone, then, or waxy flexibility, if they are present, they are very much suggestive. But if they are not absent, that doesn't rule out a diagnosis of catalepsy.
Okay, ma'am. Thank you so much. Thank you, ma'am.
Thank you. Thank you very much, Dr. Ravi, Dr. Akanksha, Dr. Nepal. I think with my co-chair's permission, I will hand it over back to Dr. Saraswati. It was a treat that we had today.
Thank you, madam. Thank you so much for your time today. We had excellent cases, and even yesterday in the autoimmune subsection, I think they discussed neurobasets. So it was surprising that we had another similar presentation, another similar case today. And just yesterday night, I happened to hear to it, and today we had another case. Also, the cases by Dr. Ravi Prakash, the rare manifestations where we always have doubts regarding pure psychiatric forms. When you have polysymptomatic forms, it's quite easy for us. The monosymptomatic forms, pure psychiatry, we are always in trouble when we have to start treatment or how long to continue treatment. I think one good point here was patient responded to treatment. There's other forms which Shruti madam would agree probably that where the response may not be as quick as this, and that remains a challenge still to us. Over to Josna. Thank you all. Thank you, Sharat sir, also for spending your Sunday today with us. And thank you to Akanksha, to LRSC for always being there supporting us.
Thank you.
Over to Josna.
And nothing more to add. I think it's been excellent discussion. I learned a lot. So with everybody's permission, and Sharat sir specifically a wonderful radiological discussion to Shruti madam, Dr. Elavarisi. Thank you so much for giving your time on a precious Sunday. And
Thank you.
if Saraswati
you.
is okay, we'll declare the session closed.
Thank you.
Thank you. Thank you.
Thank
Have
you
a good day.
Thank you.
Thank you.
Thank you, everyone.
Good day. Good day, everybody.
Thank you, everyone, madam. Thank you, Sharat sir, and thank you, Shruti ma'am.